Hi everyone, welcome. My name is Natalie and I'm working for the Better Project. And I am thrilled to have with us Dr. Chang, who's gonna talk about sexual health in T1D. So Dr. Chang is an endocrinologist at Trillium Health Partners and UTD Health Toronto and an associate professor at the University of Toronto. She has been involved with the development of the Diabetes Canada Clinical Practice Guidelines since 2003, and she served as a chair for the 2013 version. She is serving as a chair of the Scientific Planning Committee for the 2023 and 24 American Diabetes Association Annual Scientific Meetings, that is the largest international diabetes conference. In addition, she's an associate editor for the journal Diabetes Care and co-host of the podcast series Diabetes Care on Air. In recognition of her contribution to the diabetes community, she has received the National Charles H. Best Award and the Gerald S. Wong Surface Award from Diabetes Canada. She is also the creator of the MedEd Pledge, which is an initiative to increase diversity and inclusion in continuing medical education, along with CMEX, a searchable database of healthcare professionals interested in contributing to medical education. So, Dr. Chang, welcome. I don't know if I forgot anything. You can add some more if you want. So, the floor is yours, I guess.
Excellent.
Oh, just before I forgot, sorry.
Yes.
Everyone here, we cannot answer questions live, so please use the Q&A section, and after Dr. Chang's presentation, we will try to answer as much of them as possible. Go ahead. It's your turn.
Okay, wonderful. So thank you very much, Natalie, for the kind introduction and the opportunity to present what I think is an important topic that does not get discussed nearly enough. And thank you to the audience for joining this afternoon. And hopefully, I don't know the age of the audience that I'm speaking to, but I am certainly old enough to remember this group, Salt and Pepper, and their very famous song, which I think had lyrics that are very apropos to the topic that we are discussing and the importance of actually talking about sex. This would be, I think, peer groups, but also with your healthcare team. And that's something that I think we can all do a better job of making sure that it actually happens. So we're going to talk about things to discuss with your partner or your potential partner. We're going to talk about sexual dysfunction, both male sexual dysfunction and female sexual dysfunction. And then we're also going to end off by talking about the effect that hormones have on your diabetes. So to start off, I guess a question to ask is, let's say you're thinking about having sex. So how do you, in fact, prepare in the context of living with type 1 diabetes? And I think there's a little bit of a checklist that one needs to be thinking about. And I think the most important one is to have a clear and honest and open conversation with your potential partner to explain what it means to have diabetes in the context of sex, which is essentially exercise, and therefore what could potentially occur and then what your plans might be. So hypoglycemia is probably the one to be aware of because it is in fact exercise. You may want to have some juice or some Dextabs or some candies nearby should you need to reach for them. Obviously, conversations around contraception are critical for everyone to have prior to engaging in sexual activity for multiple reasons. I think in general, contraception needs to be discussed, as well as safety from a sexually transmitted infection perspective. But also in the context of diabetes, if it's the woman who's living with type 1 diabetes, you don't really want any unexpected pregnancies in the context of diabetes. And then for those of you who wear a pump, it's the age-old question of pump on versus pump off. And typically when I'm giving this lecture in a live audience, I now ask this as a show of hands. And I'm not going to ask you to type it in the chat in terms of which preference you have. But those of you who live with a pump, have already made that decision for yourself, whether you're a pump on or a pump off person. Obviously, I'm talking about if you are using a tubed pump. And then it probably changes from scenario to scenario on whether you're a pump on or a pump off person. So here is sort of a polling question. I don't know that we actually set up for polls, so you can really think about what your answer would be, whether you be pump on, pump off, depends on the scenario, or you'll figure it out when you get there, which is probably, so E is probably the one that you may want to preempt and actually have a conversation about ahead of time. And in fact, this is such an important topic that this has been discussed online in various diabetes groups, discussions around pump on or pump off. And this is an example from Diabetes UK. And within that article that talks about taking off the pump, so you certainly can take off the pump before having sex, and this is one of the more popular options. However, you want to be cognizant of time and not necessarily falling asleep afterwards and then forgetting to reconnect the pump. And then, of course, remember when disconnected, your blood glucose levels may start to rise. So therefore, make sure that you're either wearing CGM, where you can be alerted if the blood sugars change dramatically, or have a way to test your sugar when necessary. And then if you leave the pump on, then it's a matter of being a little more strategic about where the pump is and where you are and where your limbs are and where your partner's limbs are, so that there's not too much entanglement into the tubing. And then also remember, it is in fact a form of exercise. So you may want to set the exercise target prior to initiating sexual activity. And this topic is an important one. And then Beyond Type 1, which is a group that you're probably all familiar with, an online group of people living with type 1 diabetes, actually had a session on Let's Talk About Sex and had people share stories about their experience with sex and living with type 1 diabetes. And I've just taken a selection of a few of the stories, which I thought had some good lessons to take away. So this is from Holly, who is age 22, was diagnosed at age 3. And she says, if I want my pump out of the way, I wear a band, either arm or waist, to tuck my pump into, and that seems to work fine. Otherwise, it just roams the bed. We had a long, honest talk about it all before we first had sex, all around what to do if I go low, if my site gets ripped out, where we should put my pump, what to do if we get tangled. And that was the best thing we could have done, because when we arrived at those situations, we knew what to do. So I think it really drives home the point, the importance of having an honest conversation with your partner about what to do so that there's no surprises. And then this is Liv, who says 100% in the pump off camp. Where would you clip it? When the pump hits the nightstand, you know the magic is about to happen. So that's from Liv. And then this is a message from Michael. Even though I'm having fun and want to get down, my first thoughts are always be careful of the pump, be careful of the CGM, and that's a certain level of innate awareness. So just being aware of where things are. And then this story I really liked, so I wanted to include in the presentation. It was my first time in bed with a new guy I was seeing, and about half an hour in, I heard my mom's voice calling my name from outside my bedroom window. My blood sugar had gone low, but my phone was on silent, and I couldn't hear the alerts from my CGM or the calls from her, so she came over to check on me. I quickly threw on some clothes to go talk to her, but by the time I opened my door, she had already run back to her car. Luckily, my date was really nice about it, but needless to say, it was one of the most awkward moments in my T1D life. And I'm sure our audience could share stories themselves about what may have happened to them. But I think talking about it is important. I think discussing it with your partner and being prepared for the different scenarios that may occur is the main thing to take away. So now let's talk about sexual dysfunction. And let's start off with male sexual dysfunction. So for male sexual dysfunction, the potential causes are things like low testosterone. And low testosterone can be found in some of the studies reported 30 to 40% of people living with type 2 diabetes and 14% of those living with type 1. I think some of this may be skewed by age as well as by obesity, because we know that overweight and obesity, so specifically the fat cells themselves, can lead to lower testosterone because of higher estrogen levels. So this is probably a little bit skewed. However, low testosterone can definitely occur. There can also be issues around ejaculatory disorders. or it could be erectile dysfunction. So there's different types of male sexual dysfunction. And erectile dysfunction is extremely common, and age is a significant risk factor, but it's not only in older men. Glucose levels, high blood pressure, high cholesterol can contribute. Smoking can definitely contribute, and obesity itself can also contribute to erectile dysfunction. Now, when it comes to low testosterone, how do you know if you have low testosterone? So one of the symptoms is low libido. So sex drive is reduced. There could be erectile dysfunction. And overall reduced motivation and reductions in muscle mass. And if you have those symptoms, the most important thing to do is to discuss this with your doctor, is to ask the question. And then when the question's asked, then you'll get the sheet to do the blood work, because it's by blood work that we make the diagnosis. And the blood work is drawn in the morning. So the timing is important because testosterone, like many other hormones, have a variation over the course of day and night. And the peak is in the morning. So when I say morning, I'm talking roughly 8 o'clock in the morning. So 8 o'clock in the morning is the peak, and that's when you want to get the blood work done. Because if you get the blood work done at 3 o'clock in the afternoon, it may be a little bit lower, but that may be normal because testosterone does this. So therefore, make sure if you're going to get testosterone blood work done, make it first thing in the morning. There are treatments. So if in fact one has low testosterone, I think the first thing the doctor will need to sort out is why. And the causes could be central. It could be something up in the brain in the pituitary. It could be a small tumor in the pituitary. These are usually not cancers, but small tumor in the pituitary that's squashing parts of the pituitary, or a pituitary tumor making prolactin, another hormone that's squashing it. That has a different treatment. It could also be gonadal, meaning at the level of the testes. So if someone had had mumps as a child, had been kicked in the testes, or a soccer ball to the testes as a child, so any injury could potentially affect it. Or it could be, certainly with age, just sort of what's been called menopause, or menopause, meaning that the testes are just no longer working as well. So there are primary issues from a testicular perspective, or secondary issues centrally. So that your doctor will run other blood tests to sort that out. And then if replacement is required, that's easy enough to do. There are oral forms, there are injectable forms, there are gels, and there's even a underarm gel, I guess that could be said. And then there's also a nasal form, nasal spray. Now, the most effective is going to be the injectable, as well as the gels. The oral one is very ineffective, actually. The nasal spray one is also effective, but it can be costly. And then the underarm one can be effective, but also costly. And then what about erectile dysfunction? So for erectile dysfunction, again, talk to your doctor if you're noticing it. Blood tests will often be done to check out the testosterone levels, the other hormone levels, to make sure there's no easily reversible cause. And then if not, then it's usually an issue of age, or nerve function, or circulation that may be causing the erectile dysfunction. So the treatment of it is controlling risk factors like blood sugars, blood pressure, cholesterol. And then there are, of course, treatments for erectile dysfunction. These are called PDE5 inhibitors. So things like Viagra, Cialis, or Levitra are pills that can be taken that are either on demand, so you take it prior to wanting to engage in sex, or some can be taken on a daily basis at a low dose so that you chronically have some in the circulation. And this is the Cialis daily version that's also available. If those don't work, then people can do injections or gels or vacuums. And usually for that, that requires a referral to a specialty men's clinic. So that's male sexual dysfunction. What about female sexual dysfunction? Now, to discuss female sexual dysfunction, we need to remind ourselves that there's 3 phases of the sexual response cycle in women. So there's desire, arousal, and orgasm. So there are 3 phases, and therefore you can have dysfunction at any of the 3 or all of the 3 phases. So female sexual dysfunction is extremely common. These are some of the statistics that are out there, but I would take these numbers with a grain of salt, because the collection of the data are always somewhat questionable. But the bottom line is it's probably more common than we discuss. And some of the common forms of sexual dysfunction in women is hypoactive sexual desire disorder, meaning low sexual desire. There could be an issue with female arousal, and there could be an issue with orgasm. And then for some, it's pain, which is the concern. Now, all four of these things can happen in any woman, including a woman living with diabetes. So if we talk about the first one, which is hypoactive sexual desire disorder, meaning a lower desire for sex, the symptoms include the absence of sexual fantasies and the absence of desire for sexual activity. But the key part is the third bullet point, which is it has to bother you. Because if you have one and you have two, but it doesn't bother you, then it's not a problem. It's not a disorder. It's only a disorder if it's actually causing significant personal distress, and it has to be prolonged. Because everybody short term might have some issues, but then if it's prolonged, it's bothering you, and then there's the absence of these things, then it's considered a disorder. And there is this screening tool to see if you may have hypoactive sexual desire disorder. So the questions are, in the past, was your level of sexual desire or interest good and satisfying? Has there been a decrease in your level of desire or interest? Are you bothered by it? And would you like it to change? And then the fifth question on the bottom is asking for other secondary causes, which may be reversible. That would then mean it's not a central problem, but it's some other problem. So what you need to do is essentially answer yes to all of the first four and then no to the bottom. Then that would then be consistent with a diagnosis of hypoactive sexual desire disorder. Now, the issue with treating this is that the female sex drive is extremely complicated, right? The female sex drive is like the cockpit of an airplane. It's got lots of buttons, lots of levers, lots of things that are moving. There are biological things, there are psychological things, there are social things, and then there's the context. So female sex drive is very complicated, and it's not just a hormonal issue. And in contrast, some have joked that this is more like the male sex drive, which is a little bit more on and off. Now, of course, this is too simplistic because men also are complicated people, and also there is context as well as the psychological and the social. However, I think the hormone drive is perhaps higher on the male sex drive side, whereas for the female, it's usually quite complex. So when it comes to trying to address hypoactive sexual desire disorder, which can be found in any woman, but potentially in someone with diabetes, there are different things that we need to think about. So in the diabetes space, potential contribution could come from the fact that there are some blockages of the arteries from atherosclerosis, and therefore the circulation to the area may be impacted. As you know, people with diabetes could potentially develop neuropathy or nerve damage, which may reduce sensation. And if sensation's not great, why would you be interested in sex? Hyperglycemia or high blood sugars are associated with decreased lubrication, which could then make sex uncomfortable, as well as yeast infections, which would also make sex uncomfortable. And then there may be body image issues, which are very real. And if you have a body image concern, then you're not going to want to get naked and not want to be engaging in sex. And then fear of hypoglycemia could be very real. And then depression and anxiety, of course, an issue with anybody, but we also know more common with any chronic disease can contribute. And then finally, depending on the medications you're on, not insulin, but potentially a cardiac medication could also impact the sexual desire. So what do you do about it? The most important thing to do is to talk to your doctor. So talk to your team about whatever it is you're experiencing. And an interesting survey found that 3/4 of women want to talk to their doctor about it, but they would also prefer that the doctor initiate the conversation, which makes sense, right? Because this is unfortunately still a topic that's a little bit not as common. And I think it's our job as healthcare professionals to ask the question, which will then open the door and then allow for that conversation to occur. But depending on when your team may have trained, depending on the knowledge base of your team, to be honest, they may not ask you. And if they don't ask you, and this is a concern, then bring it up and ask them. And I think that's the right thing to do. And if someone were to talk to me about this, then there's some blood tests that I might do just to rule out any other kind of hormones or any other medical explanations for low estrogen and low drive. And then if I don't find anything, then we discuss potential treatments. So the potential treatment list is unfortunately not very long. So cognitive behavioral therapy. So in other words, working upstairs and trying to understand what's happening. That's not something I'm trained to do, but there are sex therapists, and those sex therapists are trained to do that and to have that cognitive behavioral therapy. And then if it's an issue of pain or lack of lubrication, then lubricants are extremely useful to help address that. Because if sex is painful, who's going to want to have sex? Nobody. And then there are some medications, most of which are off-label. The only one that's indicated is flibanserin. The only issue with flibanserin, though, is that it's extremely expensive and it doesn't work great. And it does have some drug interactions, especially around alcohol. So it is not commonly used for hypoactive sexual desire disorder. And then bremelanotide, we do not have in Canada. The bottom three, though, are available in Canada because they're used for other things. So bupropion, for example, is used for the treatment of depression or anxiety, but off-label, there are some data showing maybe benefits in sexual desire. Buspirone is used very little nowadays. And then testosterone in a postmenopausal woman could, in theory, be used, but there is a risk of her developing other issues such as hair growth, which she may not be particularly happy about. So we don't have a ton of options in terms of the treatment here from a medication perspective, but I think the cognitive behavioral therapy part is usually very effective. So that's the sexual dysfunction part. Now let's switch to the last part, which is, okay, now how do hormones affect my diabetes? I'm going to start off with men, actually. So from a testosterone perspective, the impact on the sugars is minimal. So in a man who's hypogonadal, meaning they have low testosterone, and then we replace their testosterone, they may notice a little bit of improved insulin sensitivity so that they don't need as much insulin. But that's sometimes offset because if you're feeling better, feeling more energetic, then your appetite may be improved and you may eat more, in which case you need more. But then conversely, if you're feeling more energetic, you may then be more active, in which case you need less. So I think the testosterone probably has minimal direct effect on sugars, and it's more indirect. On the female side of things, though, there's a lot more direct effect that hormones can in fact have. So if we think about the menstrual cycle is an orchestra of coordinated hormones. And this diagram on the right shows you what the hormones are doing at different parts of the cycle. So let me orient you. This day one is when you start bleeding. So this blue M represents the menses. So that's the beginning of a cycle. At the beginning of the cycle, the two pituitary hormones, which are LH and FSH, are relatively low. And then they start to build a little bit. And then there's a surge in LH that occurs mid-cycle. That surge in LH is what drives ovulation, egg popping out. That roughly happens mid-cycle. After the egg pops out, the LH falls back down, and then the LH-FSH remain low. But the LH-FSH is what's driving the other hormones that are actually causing the sugar impact. So estrogen is shown in the red here. It's at lowest during your period, and then it slowly rises as the lining builds. And then the lining builds. And then there's this surge of estrogen, which probably triggers that LH surge. Then ovulation occurs, and then the estrogen levels sort of settle back down and then drop off just before your period. Ovulation, the release of the egg, causes this rise in progesterone, which is the orange dotted line. And that rise in progesterone, the progesterone matures the lining. Estrogen builds the lining of the uterus. Progesterone matures the lining in preparation for implantation of an embryo. So then the progesterone rises, matures the lining, and 14 days later, those cells that make progesterone die. So then progesterone levels fall off, and it's that drop in progesterone that triggers the bleed to occur. The drop in progesterone tells the body, okay, there's no embryo being implanted. We don't need this lining anymore. Get rid of it. So then you shed the lining by bleeding. So there's this concert of estrogen rises and then progesterone rising and then a drop. So what does all of this do to the blood sugars? Okay, so this is just explaining the follicular phase, the luteal phase. Luteal phase is the after you've ovulated phase where there's a lot of progesterone. And then menses occurs because of that drop in estrogen, drop in progesterone, and then you bleed. But all of this up and down influences your blood sugars. So for 3 to 5 days before your period, when the progesterone is at its peak, when the orange line is at its peak, it's a very insulin resistant hormone. You need a lot more insulin during that time. Your blood sugars tend to be high. But then once your period starts, meaning the progesterone, boom, has fallen, which allows the bleed to occur, that insulin resistance goes from here to here. And then suddenly you start to have hypoglycemia and you got to pull back your insulin. That's the typical expectation around period. A lot more insulin just before your period and a lot less insulin when you're on your period. Now, the dose adjustment around your period. So during the PMS phase, because so progesterone is the PMS hormone. That's the one that gives you breast tenderness, bloating, cravings, moodiness, all those wonderful things. That hormone makes your blood sugars go up. So therefore, you're going to require more insulin. You're probably going to be more snacky. You're probably going to reach for things like potato chips, chocolate, and therefore making sure that you're appropriately bolusing for that is critical. And your insulin requirements can go up 10, 15, some women 30%. And you and many of you on a pump, I suspect, have a before the period basal settings if you're not on automated insulin, and then for on your period basal settings, because they're going to be different. Now, what about perimenopause and menopause? So one resource I encourage all of you to visit, it's called menopauseandyou.ca. So this is an excellent resource designed for people. It's not a healthcare professional resource, but it's created by healthcare professionals, by the Society of Obstetricians and Gynecologists. And it goes through what is menopause? Am I in menopause? What are the treatments? What can I do to help myself? Lots of resources, lots of really useful things. So going from right to left, not left to right, but right to left. So premenopause is when your periods are still coming normal. Perimenopause starts in your 40s, and that's when things are starting to go weird. Your periods are not quite at the same schedule, sometimes lighter, sometimes heavier. You may start to notice some early hot flashes. You may start to notice some mood swings. And then menopause is when there's been 12 full months of no period. Now, average ages are shown for you here, but obviously there are differences for different people. Now, the thing with menopause is that if it occurs under the age of 40, that's considered, I was going to say abnormal, that's not the right word. That's considered primary ovarian insufficiency. Whereas if menopause is under the age of 45, that's considered early menopause. And then anything after that is considered quote unquote normal menopause. And there are a number of things that happen during that perimenopause, menopause phase. The ovarian follicle, so the eggs in the ovaries are starting to poop out. There's starting to be very little of it. And therefore, there's less estrogen being made and there's less of that cycling occurring. And that can lead to a bunch of things, right? So that can lead to, on the left, loss of your menstrual cycle. It can lead to vasomotor symptoms, in other words, hot flashes. It can lead to urogenital atrophy, which means loss of the cells lining the vagina. So then you get sort of a drier, itchy, maybe uncomfortable area. It can affect mood. It can affect sleep. It does increase cardiovascular risk. And then it also is negative impact on the bone because estrogen helps to maintain your bone density. You lose the estrogen and the bone density could fall. So these are the things that we're concerned about when menopause occurs. What does that mean from a diabetes perspective? Well, during the perimenopause, when your period sort of shows up when it wants to show up and then doesn't when it doesn't want to, and it's not predictable, that makes it harder to manage your blood sugars, right? Because you cannot predictably put up your basal rates knowing that you're going to be in that luteal phase. You can't do that because you don't know what's happening. So there's a little bit of unpredictability there. And then the other problem is the confusion between a hot flash and hypoglycemia, because they can feel very similar. So that's where the real key is to check. So if you're wearing CGM, that's ideal. Otherwise, poke, 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 because that's the only way you're going to know, is this a hot flash or am I having hypoglycemia? And then your insulin requirements are just going to be all over the place because it depends on what part of the cycle you're in. And in a study that tried to look at it, they surveyed a whole bunch of women living with type 1 diabetes. Generally speaking, postmenopausal, after you've had 12 months of no period, the total daily insulin requirements seem to go down. The total daily basal requirements seem to go down. And there was a slight decline in kidney function, for what it's worth. But then the bolus doses seem to be maintained, and the blood sugar control overall seemed to be maintained. And that's because of the efforts of the women who were going through it. So in menopause, your total daily insulin and your basal insulin requirements may go down a little bit. But again, each woman's going to be different. So what kind of adjustments? Well, if you go on menopause hormone treatment, meaning go on replacement hormones, the advantage is that your hormones will now be stable. And therefore, you can adjust your insulin knowing what's going to happen. Also, the hot flashes go away, in which case you don't have to confuse hot flashes with hypoglycemia. So if you're going to go on menopause hormone treatment, then that could be beneficial for your sugars. But the reason to go on menopause hormone treatment is not for your sugars. The reasons will be because of terrible hot flashes, because of mood disturbances or sleep disturbances. Those are the usual reasons we would use hormone replacement therapy. If you use the hormone replacement therapy that is cyclical, because there's two kinds. There's a kind where it's continuous and you don't get a period. And there's a kind where it's cyclical, where you mimic what the menstrual cycle does. You take estrogen regularly, then you take progesterone for 14 days, and then you stop the progesterone, and then you get a period. So if you're doing that kind, then you'll adjust your insulin accordingly, because when you're taking progesterone, which was the orange line, then your insulin requirements go up, and then you would take more insulin during that time. The last bit is that don't forget that menopause is a time of higher cardiovascular risk, because estrogen is somewhat protective from a cardiovascular perspective. So when you lose it, you're also older at that time, then there is cardiovascular risk. So in making sure that your blood pressure is well controlled, your cholesterol is well controlled, you're physically active, all of those things are particularly important when you're in menopause. So remember the other health issues. Remember about bone density and checking for osteoporosis. Remember to get your mammogram, and remember to control other cardiovascular risk factors. So to summarize, and we've got lots of time for questions that people may have, talk to your partner if you're thinking about engaging in sexual activity for the various things you should talk about anyway, but from a diabetes perspective about what hypoglycemia might look like, what to do if it happens, make a decision of what to do with your pump, if you're on a tubed pump, pump on, pump off, what to do in different scenarios. When it comes to sexual dysfunction, it is common, and we should be asking about it. But if we don't ask about it, please bring it up. From a male perspective, there's male sexual dysfunction in the form of low testosterone and or erectile dysfunction. Female sexual dysfunction could be in the realm of desire, which is probably the more common one, or arousal or orgasm or pain. Make sure that you discuss it. And if your doctor may not have expertise in it, they could at least make suggestions for a sex therapist, or you can also find a sex therapist in your area. But then things like lubricants are really useful to address the pain to ensure that it's not painful. Menstrual cycle will affect your blood sugars, particularly in that 14 days before your period. So insulin requirements will go up. Perimenopause is a challenging time because of the fluctuation. Menopause, things are at least smoother, but then you need to be aware of things like hot flashes and trying to differentiate between hypoglycemia and hot flash. And then also, if you choose to go on hormone replacement therapy, then knowing what hormones and how it could impact your blood sugars. And then finally, don't forget about the overall cardiovascular risk that's higher when you're in menopause, and ensuring that all of your other risk factors are well taken care of. So with that, I thank you very much for your attention, and I will stop sharing and we can open it up for any questions that the audience may have.
Thank you very much, Dr. Cheng. This was very interesting and instructive. I think people probably learned a lot, and there's a lot of things to remember when you have type 1 diabetes, I think. So that was very fun to hear. Uh, we have only one question up to now, but please feel free to ask any questions you might have. So the question we have is, how does taking oral birth control impact diabetes management?
Yeah, that's a great question. So, oral birth control, oral contraceptive pills are hormones. Most of them contain both estrogen and progesterone, and most of them are designed so that there's a week of a break where you're not taking the hormone. So, on that week of a break, then the progesterone that you had been taking leading up to that break is now gone. So, your insulin requirements will often be much lower during the bleeding, during the period part, because you've got less of the progesterone circulating. There are some where it's more continuous. So then you may only have a bleed every 3 months, in which case that may be a little bit smoother in terms of the blood sugars. The change when you first go on the pill depends on what your situation was before, right? So if you went on the pill because you were not getting periods, then when you first start the pill, you may find your insulin requirements go up because there's suddenly progesterone that hadn't been there before. But if you went on the pill because your PMS was so really difficult and huge variability and you're really struggling, then insulin requirements and diabetes is smoother when you go on the pill because that whole roller coaster is gone and you've now smoothed things out. So the change when you first go on depends on where you start from. But then the actual effect while you're on it depends on the kind of pill you're on. And just remember for all of them, during the week of your period, your insulin requirements usually are much lower.
Thank you. I have Terry here asking, I just went on HRT and I was wondering how would I know when menopause is over and when I would stop taking it?
Right, great question. So you just went on hormone replacement therapy. And presumably by asking this question, that means when you started it, your periods had not been fully gone for a year. Because if your periods had been fully gone for a year, then you are menopausal. The periods are done. And you're taking the hormone replacement therapy for reducing hot flashes. But sometimes we start it earlier than that because the hot flashes are just intolerable. So to be honest with you, there is no way to know for sure until you stop the HRT and see if there's no period for a year. But that's kind of a question that we do not need to ask because the more relevant question is at what point would I stop? What point would I stop has nothing to do with whether you're fully in menopause or not. The reason you're taking it is to avoid hot flashes. Hot flashes can be 5, 10, 15 years into menopause. You can still have hot flashes. So what I would suggest is to take it for at least a year or two, 1 to 2 years at least, because you went on it for a reason, and it's probably because you had a lot of symptoms. And then if you were curious, what you could do is start to lower the dose of the estrogen part. Not stop cold turkey, but lower the dose, maybe cut it in half, maybe take it every other day, and then over the series of the next few months, lower the dose until you see if the hot flashes come back. And if they do, but they're very infrequent and you can live with it, then you can stop. So we don't go by blood tests. We don't necessarily go by other things. We would just go by your symptoms as we wean off to see if you no longer require it.
Thank you for the answer. Another question here, Kathleen, should I discuss insulin requirements during perimenopause with my endocrinologist, or should I just rely on my CGM and adjust on a day-to-day basis?
So I would always encourage having that conversation with your endocrinologist. However, I hate to say this, but not every endocrinologist is going to be comfortable having that conversation. I shouldn't be comfortable. Everybody's going to be comfortable having that conversation, but not everybody's going to know necessarily what to do about it. Let's put it that way. Because they, as men, would never have experienced perimenopause, or even as a younger woman would not have experienced it, or may not have really had that conversation. So you should raise it and see what they have to say. I would also raise it with your team. Because often it's our diabetes nurses and dietitians and educators who can give us a lot of advice around there. But the advice is going to be what you said as your last point, which is you're just going to need to rely on your CGM and adjust on a day-to-day basis because it's unpredictable. And listen to your body, right? So there's going to be clues that a period's going to be coming. It's that all that whole premenstrual stuff, right? So if you start to notice vaginal discharge, if you start to notice your breast tenderness, you start to notice you're snapping at people, you start to have some zits on your chin, you start to like all of those lovely things, you know it's coming. And therefore you're going to preemptively go up a bit on your insulin and your basal rates because you know that is going to be higher. But then once the period stops, you got to know to drop that insulin dose. So yes, have the conversation, but don't be surprised if you don't get anything overly useful because it is very individualized.
I have a question. What about clinics like specializing in perimenopause, menopause? Are they can they answer question about T1D, or is it like two opposites thing? And
Sorry, I missed that part. Can they ask what that? What did you
well,
say?
if you're living with T1D and you go to that type of clinic, specializing in menopause or perimenopause, will they know about like T1D and effects on sexual
Um,
health?
they likely will not, right? But they will be able to help with hot flash treatment. They'll be able to help with vaginal dryness issues. That they'll be able to address the actual perimenopausal symptoms, but they're unlikely to be able to tell you what to do with your insulin. So just know the general principle that when the bleed happens, you need less. Prior to the bleeding, you need more, and then listen to your CGM and adjust accordingly.
Okay, thank you. And I guess we have time for this last question. I have PM1 and PCOS. I don't know what it is. Obviously, can take metformin and my weight and diet are good. What else is available for symptoms management?
Perfect. So the person has type 1 diabetes and polycystic ovarian syndrome.
Okay.
So I would argue you can take metformin. So metformin in PCOS is used for the insulin resistance that is part of PCOS. Just because you live with type 1 does not mean you can't also have insulin resistance, right? So in other words, you can have type 1 diabetes because your pancreas is no longer making insulin, but you can also have insulin resistance. And that actually just makes your type 1, it adds another layer of complexity when you're treating it. You need a little more insulin to treat your diabetes, but you can also have insulin resistance. So the metformin addresses the insulin resistance, which helps with the PCOS. And it may end up that you'll need less insulin when you're on the metformin, but you absolutely can use the metformin. Now, in terms of weight and your food choices are great. That's wonderful. What else is there? So for the hyperandrogenism symptoms, so for the symptoms of high male hormone, which are acne, hair growth, loss of hair on the head, there are specific medicines to lower androgens. So specifically spironolactone. So spironolactone is a very old drug. It's like 80 years old drug, which is a weak blood pressure drug that will also lower male hormone levels a little bit. So your doctor might choose that. The oral contraceptive is another useful tool to, again, just smooth out the hormones because we take over the system. So it's really spironolactone, oral contraceptive, and then local treatments for the hair or local treatments for the acne.
Thank you very much. So I don't see any more questions. It's past 1:45. So what I can do is invite everybody to stay tuned on our Facebook page and Instagram because we'll have another webinar in November coming up for the Diabetes Awareness Month. So please follow us and you'll know about it a little bit more later. I will thank you again, Dr. Chen. That was very interesting presentation, and I guess a lot of people are going to watch it afterwards when it's going to be on our website. So thank you again. Thank you for all the participants, and I wish you a very nice rest of the day.
My pleasure. Thanks for having
Thank
me.
you.
Bye, everyone.
Bye-bye.